In this lecture, we are going to see trigeminal neuralgia. It is also called as tic doulorex, trifacial neuralgia, and Foucault's disease. Why it is called tic doulorex? It is only applied when the patient suffers from spasmodic contractions of the facial muscles. So, these are the synonyms for trigeminal neuralgia. Trigeminal neuralgia is an extremely painful condition as it is unique to human beings. Next, moving on to etiology. The first one is dental pathology, pathosis, maybe due to galvanism, and next one is excessive traction. It is excessive traction of the various divisions of the fifth nerve, and allergic, maybe allergic and hypersensitivity reaction causing edema of the trigeminal nerve root, and next to ischemia. Various portions of the trigeminal pathway might be responsible for the paroxysm of the pain. Next, moving on to important point, that is compression distortion phenomenon. Here, the compression distortion phenomenon, which is usually caused by arterial loops of atherosclerotic vessels. Vessels become elongated with advancing age and with atherosclerotic involvement gaining abnormal position by wedging into the space between the progressive material elongation phases of adjacent nerves. They later suffer myelin injury and pain result. So that it compresses the nerve root of the trigeminal nerve. So the compression distortion phenomenon is also accepted. Next, moving on to mechanical factors like pressure due to aneurysm of the intrapetrous portion of the internal carotid artery. It is also produce the pain. The next etiology is anomalies of superior cerebellar artery. It is the most recently blamed cause for trigeminal neuralgia. It lies in contact with the sensory root of the nerve and implicated as a cause of demyelination. Surgical elevation of artery or decompression of the sensory root has high success rate in the relieving paroxysmal pain. And next is secondary lesion conditions such as carcinoma of the maxillary antrum, nasopharyngeal carcinoma, tumors of peripheral nerve root. These are the etiology factors for the trigeminal neuralgia. Next, moving on to clinical feature, age and sex distribution. Most commonly, it occurs before 35 years of age and mostly occurs in the women compared to men, and more common in the right side than compared to the left side. The ratio is 1.7:1. The nature of the pain. The pain is paroxysmal, lasting only a few seconds to few minutes and is usually extreme intensity. It may be described by the patient as resembling knife-like stabs, lightning, electric shock, stabbing or lancinating type of pain. That's why it's called tic doulorex. So, these are the important clinical feature. And mainly, the attacks do not occur during sleeping. During the intervals between these violent experiences, there is usually no pain or mild or dull ache. So, these are the important clinical feature. So, it is mostly common in the woman and most common in the right side. It is very important. And attacks do not occur during sleep. Next, location of the pain. The pain is confined to the trigeminal zone, nearly always unilateral, and it never crosses the midline. So, important point here is always unilateral and the pain never crosses the midline. In trigeminal nerve, it has three branches: ophthalmic, mandibular and maxillary branches. In three branches, mandibular and maxillary divisions are more commonly involved. These are the important clinical features of the trigeminal neuralgia. Next, moving on to aggravating factors. The pain is provoked by obvious stimuli to the face, a touch, draft of air, any movement of the face like talking, chewing, swallowing may evoke a lancinating attack. Later, the pain may be so severe that the patient lives in constant fear of an attack. Often there is transitory refractory period after the attack. There is pain reliefs sometimes. As the attack occurs, the patient may clutch his face as it terror of the dreaded pain. So these are the aggravating factors. Next, moving on to trigger zones. It is important in trigeminal neuralgia. The trigger zones which precipitate an attack when touched are common on the vermilion border of the lips, ala of the nose and cheeks, and around the eyes, because these areas are supplied by the trigeminal nerve. Vermilion border of the lips, ala of the nose, cheeks, and around the eyes. Here, this picture showing the trigeminal nerve supply, ophthalmic branch, maxillary and mandibular branches. So most commonly involved branches are maxillary and mandible. So the trigger zones are vermilion border of the lips, ala of the nose, cheeks, and around the eyes. Next, frozen or mask-like face appearance is also a clinical feature of this condition. Excess lacrimation, conjunctival injection, intense headache, effect of activities of patient. Because of this pain, patient unwilling for shaving, unshaven face, avoid brushing, poor quality of life, and indiscriminate dental extraction. It is very common for this patient to undergo indiscriminate dental extraction on the affected side without any relief from the pain. Because of the pain of the trigger zone and pain fiber distributions often mimic pain of odontogenic origin. So we have to know the etiology of the condition, if it is dental condition or it is due to the trigeminal nerve involved. Next, moving on to diagnosis. Abrupt onset of pain with trigger point. Pain is extreme in nature with less time duration. Pain is localized to known distribution of trigeminal nerve. So here the involved area due to the trigger zone, and it is never cross the midline and it is unilateral. These points are used for making the diagnosis, and spontaneous remission occur. This is the diagnosis. Next, moving on to differential diagnosis. One is migraine. It is a very common condition mistaken for trigeminal neuralgia. It is also known as Horton syndrome, histamine headache, histamine cephalgia. But the severe type of periodic headache is persistent at least over a period of hours, and it has no trigger zone. These are the differentiating feature. In migraine, there is no trigger zone, and it is over a period of hours, its pain is persistent. And next, sinusitis. Here the pain is not paroxysmal and no triggering zone. Toothache, this can be easily identified by examining the oral cavity. Next, fourth differential diagnosis is multiple sclerosis. It occurs because of the autoimmune process. Specific clinical feature are Charcot's triad, that is intention, tremor, nystagmus, and dysarthria or scanning speech. These are the differentiating feature. How to differentiate multiple sclerosis from the trigeminal neuralgia? Charcot's triad is used. Next, tumors of nasopharynx. Tumors of the nasopharynx can also produce similar type of pain manifested in the lower jaw, tongue, and side of the head with associated with middle ear deafness. This complex lesion is called Trotter's syndrome. So here middle ear deafness also present in tumors of nasopharynx, but trigeminal neuralgia, there is no middle ear deafness. Next, the next differential diagnosis is post-herpetic neuralgia. Neuralgia occurs after attack of herpes zoster virus. So pain is usually involved in the ophthalmic division. In trigeminal neuralgia, pain most commonly occur in mandibular and maxillary divisions. Here ophthalmic division is involved. We have to take the history of skin lesion prior to the onset of the neuralgia. Usually it's the diagnosis. And next differential diagnosis, Costin syndrome. It is a mandibular joint syndrome. So these are the differential diagnosis for trigeminal neuralgia. How to differentiate from migraine, sinusitis, multiple sclerosis, tumors of nasopharynx, post-herpetic neuralgia, and Costin syndrome. Next, moving on to management, medical treatment, trichloroethylene inhalation, topical capsaicin cream, anticholinergic drugs, dilantin, carbamazepine, oxycarbamazepine, baclofen, combination therapy, chlorazepam, anti-inflammatory agents are used. Here, the main drug of choice is carbamazepine. It has a special effect on the paroxysmal pain. The use of this drug causes paroxysmal to become separated by intervals of freedom for weeks to months or even years. Here the dosage is 400 to 800 milligram per day, and main point we have to note it is dosage should not exceed 1200 milligram per day. And side effect of carbamazepine include dizziness, unsteady gait, gastrointestinal distress, hyponatremia, skin rashes, and aplastic anemia. So main is aplastic anemia is a side effect of the carbamazepine. So after the completion of the treatment, we have to check the complete blood count and platelet count. Next, oxycarbamazepine and baclofen. Mainly baclofen is an antispastic drug. The starting dosage of baclofen is 5 mg 3 times a day. Combination therapy. So it is most commonly used. The combination of dilantin and carbamazepine and chlorazepam and anti-inflammatory drugs also used. Main point here is no NSAIDs. Non-steroidal anti-inflammatory drugs are mostly not given for the treatment of trigeminal neuralgia. Next, moving on to surgical treatment. Injection of the nerve with anesthetic solution, injection of the nerve with alcohol, nerve sectioning and nerve avulsion, that is peripheral neurectomy, electrocoagulation of Gasserian ganglion, percutaneous radiofrequency trigeminal neurolysis, decompression and compression, and rhizotomy, gamma knife radiosurgery, bulbar trigeminal tractotomy. These are the surgical treatment for trigeminal neuralgia. So we have to remember the important points. That is another name of trigeminal neuralgia, that is Tigg-Dowler-Rx, trifacial neuralgia and Fothergill disease. And in etiology, compression distortion phenomenon, anomalies of superior cerebellar artery we have to remember. And clinical features, before 35 years and most commonly in women and more common on the right side, 1.7:1 ratio. And why it is called Tigg-Dowler-Rx? And attacks do not occur during the sleep, and the pain mostly or always on the unilateral, never crosses the midline. And most common divisions involved in trigeminal neuralgia are mandibular and maxillary divisions of trigeminal nerve. And what are the trigger zones? Vermilion border of the lips, ala of the nose, cheek and around the eyes. These are the trigger zones. And how to diagnose and what are the differential diagnosis. And next, moving on to management. In management, carbamazepine is mostly given. That carbamazepine side effect, that is aplastic anemia. So we have to check the complete blood count and platelet count. It is very important. And no NSAIDs are given for the treatment. And what are the surgical procedures for the trigeminal neuralgia? These are the important clinical points we have to remember, or theoretical points we have to remember. Next, and what is Costin syndrome? Mandibular joint syndrome.